Good evening all. I hope I'm audible and visible. Sure. Okay. So let's start the session. The session is on a very important topic in our body, that is the mammary gland, or what we call as the breast. Simplified anatomy. I'm Dr. Ankit Khandelwal, your anatomy educator, MBBS and MS in anatomy. Let's proceed with the topic over here. Just a second. Okay. Yes. Fine. So here we are. This is the test calendar for the month of March. You can note down all the various tests which are going to happen this last week of March. So we have orthopedics, medicine, pharma, mixed bag, anatomy, mixed bag, and NEET PG tests. These are all the tests for the month of March. Other few things over here. This is All India mock test. Please mark the date and the time. March of 27th. March of 27th, 9 AM. You can use the code also, that is Dr. Ankit Live, to unlock all these courses to enroll over here also for this weekly test. Then we have this previous year questions bank. So this is a new thing which is launching, that is previous year question bank for all the PYQs. So it's a very important feature and a useful feature for our competitive exams. MBBS Prof 1. So all the Prof 1, if you want to go with the hand in hand with the next exams and want to improve your understanding and concepts, this is the course for the Prof 1. Benefits of Plus and Iconic in which we get also prep ladder. These are all the toppers of the previous exams. These are special classes which we take normally on a daily basis. These are some of the features of the special classes. Here we have this NEET PG revision batch. For 1.5 months are left by now. After this we have this FMG batch also coming up, and this is a NEET PG subscriptions, different time period. You can use the code which I already told you. I'm writing it again over here. That is Dr. Ankit Live, L-I-V-E Live, right? There is a Plus and Iconic subscription. Nowadays new subscription which has added up, that is a light subscription, LIT. So some features, depending on if you don't need all the features, if your basic concepts are fine but you know to revise more of the MCQs, there's a light subscription for that. Okay, let's proceed further with the topic. The topic of discussion over here is our mammary gland. Just a second guys, let me see over here. One second. Just a second, let me see. Okay. I hope I'm audible and visible. It is showing on one side but not on the other side. Just a second. Just give me a second. Okay. Yeah, I hope it is fine. So here we have this topic, that is mammary gland, simplified anatomy. Let's start the topic. Till now we were just discussing on all the important parts of Unacademy. But let's proceed now. Few important things. We are simplifying the topic. The topic is very important. Now, the first thing that comes to your mind, whenever you start learning any topic or listening to any topic, first question that should come to our mind is why? Why are we reading this topic? What is the importance of this topic? Now, mammary gland, it's a part of body, fine. But what is the use of mammary gland clinically as a doctor? See, it is basically the function of the mammary gland is to provide nutrition for the newborn. That is the main function of this mammary gland, right? So it is essential for living. When a newborn is born, obviously the main thing that he needs for survival is mother's milk. That is coming from the mammary gland. It is a source house for the milk secretion. Second thing is because of its location and because it is related to the pregnancy and delivery of the baby, it is under various hormonal influences. The organ over here is under hormonal influences, that we can understand. And therefore the reason that in a life cycle of a female, there are various hormonal changes going every month or after a few decades. Therefore, the pathology in this particular organ is very diversified, and there are many pathologies, ranging from simple skin infections to mastitis, to inflammations inside, to ductal problems, to carcinomas. There's a whole range, and you all must be knowing that the carcinoma of the breast, the mammary gland carcinoma, is the most common carcinoma that occurs to the females worldwide and also in our country, that is India. So that is some of the reasons we should know, the importance of this organ for the normal living and also as a doctor, why should we devote our time to this? So that is the main thing. Now second part is, let's come to the topic where it is present. For we need some hint of embryology over here. Why? We'll tell you. This is the mammary line or the milk line which is said. It is from axilla. It is from axilla to the groin over here. It is from here to here. Now from here to here, you can have mammary glands anywhere, but in humans and Homo sapiens, normally it is around this thorax part where the development of the mammary gland occurs. While if you look at the lower animals, they have this whole series of breast development right from the axilla region to the groin region. So it is known as the mammary ridge or the milk line. But in humans, normally it is present. Now why we need to know this? Because if there is accessory or supernumerary breasts or supernumerary nipples, it will happen only in this milk line. So you should know the location of this. So if you tomorrow see a patient who has some extra nipples or extra breasts, they will be over here, and it is nothing to worry about. It is just a congenital variation. No need to worry much about it, unless and until it has some different pathologies in itself. So we should know this. Second thing comes that, sir, how is the breast developed? And do breast is present only in females or is it present in males also? It is present in both male and female. Yes, breast or mammary gland is present both in both the sexes, both in males as well as females. But in males it remains rudimentary, and in females it has a function. I've told you already about the function. What is the function of breast in females? So males it normally remains rudimentary. Okay, fine. So it happened on this milk line, and how does it develop? One more slide I want to show you over here so that your basics are well versed. Before showing this, I want to tell you a few things, that where does it develop and how does it develop? Two words we should know about the development of the mammary gland. Two words are, first of all, it is developing from an ectoderm. So what happens first in the initial part of the intrauterine life, around the second month when the development of the mammary gland starts, this invagination. There is what? There is invagination. Invagination of the chest wall ectoderm. The ectoderm. In the second month of intrauterine life, that happens. Now, I want to show you the invagination that is occurring over here. This is the invagination which is being shown from the chest wall ectoderm. Now, obviously, as the time passes on, it divides and redivides and redivides. So there are some ducts which develop. But remember, in the beginning, it is invagination. Now, just before birth, after this, just before birth, so just before birth, both in male and female, it is common to both male and female. Just before birth of the child, what happens is that this invaginated ectoderm now everts out. What does it do? It everts out. It everts out. That is why we have that protruding nipple and areola. Areola is a dark pigmented skin which is around the nipple. So just before birth, it everts out. Now, if it does not evert, you have a congenital retracted nipple. If it does not evert out, suppose there is a boy or a female or boy girl both, if it does not evert out, they will be retracted, but that would be congenitally retracted nipple. So we should know that if you see a retracted nipple of any person, you should ask him or her that is it recently retracted or was it from the beginning, from the birth of the particular person. So we should know that if this process does not occur, minus you have a congenitally retracted nipple. What difference will it make? If the person says, no sir, it was from the beginning, since the time I know, since the time I remember myself, it was from there in the beginning. So you don't have to worry about it. But if it is recently retracted nipple, then you can think of any growth which is happening inside the mammary gland. That is an important thing that you have to ask of a retracted nipple which you see in any patient. Clear? So this was one thing which you should know, that initially there is an invagination, and just before birth there is a eversion or evert, or the ectoderm it everts out and it forms like this, right? So that is basic. I thought we all should be aware of this. Now let's proceed further. Basic. Let's come to the gross anatomy of the mammary gland. How to simplify it. In humans, as we said, it is normally lying in the chest wall area. So vertical disposition of this gland is said to be from second to sixth rib. Okay, and horizontal disposition of this mammary gland is said to be from the lateral border of the sternum to around the mid-axillary line. Some books may say anterior-axillary, but let us say it a mid-axillary line. Theoretically, it is from here to here. But that is a theory part. And so, it's false. It's totally true. That the vertical disposition from second to the sixth rib and the horizontal disposition is from the sternum to the mid-axillary. But in practical purposes, the extent of the breast is much more than this. The extent of the breast is much more than this. Normally, in practical purposes, you may see the breast that is coming from the clavicle. It may go to the 8th or 9th rib. Why should we be knowing this? Because if tomorrow you have to do a surgery or any procedure over the mammary gland, you should know that practically it is not above the 2nd rib also you can find breast tissue, and below 6th rib also you can find the breast tissue, and laterally it may reach, it will start from this one, may reach the latissimus dorsi level also, the lateral border of the latissimus dorsi. So you should be knowing the extent of the breast. Extent of the breast is very important, right? Now this is the normal extent of the breast, but there is a axillary, sometimes there is a axillary, we call it as axillary tail also. So apart from the chest wall ectoderm, there is a prolongation, a continuation of this breast tissue right going into the axilla. That is known as axillary tail or axillary tail of Spence. Now this axillary tail, which is going towards the axilla, axillary tail, it may be palpable in few persons. Mainly in females it is palpable. Not in all, there are few it is palpable. But what is the use of this? Use of this, there is no significant extra use. I mean, it's just a part of it. But we should be knowing that if this axillary tail enlarges, it could be a good differential diagnosis of the axillary lymphadenopathy, because axillary lymphadenopathies are also in this area and the axillary tail is also in this area. So we should knowing that okay, this is there. But if we are palpating it, it could be a it could be, normally it is a lymphadenopathy, but yeah, we have to keep in mind that it could not always be a lymphadenopathy, it would be overgrowth. It could be overgrowth of the axillary tail, which is a part of the normal mammary gland. Clear? So that was the extent and some parts of it. So what we do is basically, we take the midline, we take the sternum over here, and we actually divide the breast on both the sides into 4 quadrants. We divide the breast, both sides, into 4 quadrants. Simply, that is for practical approach, clinical approach, we do this. And there is a clavicle over here, fine, it's clavicle going like this. So what we call it as upper medial quadrant, okay, lower medial quadrant, upper lateral quadrant, lower lateral quadrant, same over here. Upper medial, upper lateral, lower lateral quadrants. And this upper lateral quadrant, this is the one which may have an axillary tail that goes around this. Okay, so that was a vertical disposition, fine. Axillary tail also we have seen. The other thing, this is what you see grossly from the front, from the anterior view once you try to examine the patient. But now we should be knowing exact location beneath the skin. What should we call it as? Where is the breast? So here is a picture showing you both the breast in male and female. So the location is normal in a male and female. What is the difference you can see over here? That in females there is more of fat tissue. In females there is a more fat tissue in male. I mean, there could be if you have gynecomastia, but the main importance apart from this accumulation of fat that depends on the body fat distribution, there is alveoli and lobules which are present in females only, not in males. Alveoli and lactiferous ducts and lobules present only in females, not in males. Okay, so that was one thing which I told you, and we have seen the quadrants. Now let's move a step further, more into anatomy. Now we all know when we start dissection, we say okay, this is the skin, then we have a superficial fascia, then we have a deep fascia, then we can have muscles, we can have bones, we can have all other things, fine. Now when this chest wall, we also, like abdominal wall, we read the thoracic wall also, right from skin, superficial fascia up till the parietal pleura. We have this whole thoracic wall. Where is the mammary gland actually lying over there? So if you talk about the thoracic wall, we have from skin to the parietal pleura is what we study, and we say okay, this is the whole thoracic wall, right? Where is the breast mammary gland over here? Breast lies in the superficial fascia. We have to understand this. Breast lies in the superficial fascia. In the previous session, just before this session, we took a session on the pectoral region, if you remember. We discussed there the pectoralis major is covered by a fascia known as pectoral fascia. And that is a deep fascia. So what does it tell? It tells us that the breast is, or the mammary gland is, superficial to the pectoralis major and its covering fascia. So remember this, the breast lies in the superficial fascia, and therefore it is superficial to the pectoralis major, the major muscle which is present beneath the mammary gland. It could be a part of serratus anterior also, there could be a beneath this, below, there could be a part of rectus abdominis muscle also, external oblique muscle also, but mainly it is the pectoralis major. So breast lies superficial to the pectoralis major. We have to understand this part here. So if you contract your pectoralis major, the mammary gland is superficial to that contracted muscle. Okay, got this point? Okay. So it is also said, I mean, When we talk of glands in histology, in first year anatomy we talk of histology, we say glands are what? Glands are invaginations of the surface epithelium. What is breast over here? Same thing. As I told you in embryology, it was invagination of the ectoderm. So same thing happens over here. So breast is also said to be a modified sweat gland. In simpler terms, breast is also defined as the modified sweat gland. So you understand that is basically from the epithelium of the ectoderm invaginating, which is forming the mammary gland. So it is in the superficial fascia, and that is superficial to the P major muscle. I hope the point is clear. Now, what is the other features of breast over here? Now, if you look at the tissue of the breast, it may look very complicated, sir, how to remember this? Yes, it is very, very simple. Just listen to me carefully for the next couple of minutes. What is there inside the breast? Inside the breast, you have the fibrous tissue. You have the fibrous tissue. There is also what you will see in the histological slides. There will be fibrous tissue, connective tissue, which is connecting all the tissues. But you should know, what is this organ for? What is this organ for? This organ is for the production of the milk. So you will have, in a female breast, you will have the milk is it is a modified sweat gland. So glands have ducts and alveoli. So ducts and alveoli. And these ducts and alveoli, they will form some lobules. Lobules numbers could be very varied, from 10 to 100, some book says, but average comes out about between 15 to 20 lobules. It is a collection of 15 to 20 lobules. Okay, this collection of this, the duct and the alveoli. That is a function. You should know the function of the organ, so that should be there inside the organ or not. But how to support this? We have the connective tissue. But the milk production from a woman's breast or mammary gland is not throughout her life. It is only when that is required. In the lactation period, that is required. What after that? What after that? You know, this will not function. They don't produce milk all the time. So you have the supporting tissue around it, that is a fatty tissue. This is varied. This is varied, and also it is under hormonal control. So when the lady becomes pregnant, this fatty tissue, the amount of fat in the mammary gland increases substantially. So the volume of the breast increases because amount of fat tissue increases, and there is a rapid division of the alveoli for the production of milk. Both things happen side by side. Both things happen side by side. So basically these three things are present inside the mammary gland. This is the function that is supporting it, fat, and supporting everyone is the fibrous tissue or the connective tissue over here inside the breast, right? But sir, if you look at the position of this mammary gland, it is present in the anterior chest wall, and so it becomes quite big. So with the gravity, it should sag down always, but it doesn't happen. Why? The reason for that is, if we now look at a sagittal section, there is something which is known as the suspensory ligaments or ligaments of Cooper. So in this fibrous tissue, there are present Cooper ligaments, which is holding the breast right from dermis to beneath the, or you can say deep to the mammary gland. So though there are few ligaments which run from the skin and they go through the breast tissue, they fix it behind the breast tissue. This is known as the retromammary space. Let me show you that also. This is a sagittal view. This is a sagittal view. Mammary gland, this is all the nipple which is shown over here. This is all the breast tissue. You can see the alveoli over here, the ducts over here, the fatty tissue, the yellow color shown. And what are these? These are the ligaments of Cooper. You can see they are going from the dermis and they are going behind the breast. Now, look over here very carefully. This muscle is the pectoralis major. It is covered by a fascia known as pectoral fascia. That was the deep fascia, if you remember what we discussed, right? So this whole structure anatomically is basically superficial fascia. Clear? Therefore, the Cooper's ligament, they go from dermis and they pass throughout this breast and they reach the retromammary space, which is being shown over here. That is actually a part of superficial fascia only. Understood this part? Now, why is it? Because it has to hold the organ. Because if it is, imagine if there is no Cooper's ligament, the breast will sag down, and then there will be kinking of the lactiferous ducts. Yes or no? So what happens is, that's the role of Cooper's, and this whole alveoli, they pass their secretion from the ducts. And where do the ducts open? There's 15 to 20 lobules were there, so there will be around 15 to 20 lactiferous ducts. Now as this, imagine this is the alveoli over here, this is giving rise to ducts, and as these ducts, they come close to the nipple. Before that, they have a small swelling known as lactiferous sinus, and then they open out into the nipple. So all these ducts, they open into the nipples. Remember this. So if you look from the front, you have this nipple. Now nipple has a corrugated skin, opening of all the lactiferous ducts, and it has sweat glands. So around the nipple, what we see is the hyperpigmented area that is present both in male and female, that is known as the areola. This is the areola. Now, a quick word about this tissue known as areola. This is the nipple over here, and that is the areola. It is a hyperpigmented. What's the use of areola? I mean, nipple is fine. There is opening of the ducts over here in females, not in males, because in males you don't have the ducts and the alveoli. So, okay, fine. Nipple is okay. We got, but what is the use of areola? Why is this structure over here? What was, if you go back to the lecture, what was the main function of the mammary gland? To provide nutrition to the newborn child. That's it. One line, that's all. So, imagine a newborn child sucking milk from here. Now, this nipple may get dry, it may develop cracks, it may get damaged. Right or not? Because the milk is coming out of it, then after a while, all the milk has gone from the breast, now it is dry. So, it may develop cracks. Now, when there is sucking reflex from the babies, the child, and from the mothers, this areola over here will have sweat glands and sebaceous glands. Sebaceous glands over here, in pregnancy they enlarge and we call them as glands of Montgomery. Montgomery, that's the name of the scientist, but these are basically sebaceous glands. What they do is they lubricate the nipple all the time when the child is sucking the milk, and after that also. That is the importance of areola. Because of the presence of sebaceous glands which enlarge in pregnancy, known as glands of Montgomery, and that is protecting the nipple. Because if imagine both the nipples of a lactating mother are damaged, milk is not coming out, the baby may die. Simple as that. In remote places, when there is no other services available, in peripheral areas, the baby may die also, because baby is not able to feed anything. So this is one thing which you should know about the importance of areola. Now coming back over here, this is what you saw. We have seen the fibrous tissue, we are seeing the fat, we are seeing the alveoli, the ducts, and where the ducts opening. This is the basic anatomy. Now keep that in focus. The muscle is behind. This all is superficial fascia. The muscle is behind, right? So therefore, if you look at the staging also of the carcinoma breast, because that is the most common carcinomas, when the breast carcinoma, it fixes to the underlying wall, that is, I guess, stage 4, because it has gone outside the tissue, of the confines of the tissue. Now it is involving the chest wall, that is the pectoralis major and other structures around it, right? So that was sagittal view. Now let us proceed further, and what else we have now? Very important slide over here. Before showing you this slide, we should know the basics. Why are we studying? When we are studying because of their various pathologies, but the most common pathology, most important, not the most common, but the most important one that can take lives of patients is the carcinoma breast. Now carcinoma breast mainly spreads via lymphatic. So we should know the lymphatic drainage. We should know the lymphatic drainage. Before knowing the lymphatic drainage, we should know what is the blood supply. Where is the blood coming from? Because as a thumb rule, we should be knowing that the lymphatics normally follow the path of the vessels. So what's the blood supply of the breast or the mammary gland? That is one point that we should be very well aware of. Okay, clear? Let us see blood supply. Now, we know that this mammary gland is in the chest wall. So what are the various arteries that you guys can think of which is around the chest wall? Simple as that. You don't have to cram anything, just think that there is a organ in the entire chest wall. What are the arteries which I can think of? What are the arteries I can think of? No. So if you can imagine that this is the position of the heart and the aorta is coming out of it, and then the aorta goes back. It doesn't go front, it goes back. So the descending aorta is basically present posteriorly. Fine, gone. Right. Now this arch of aorta basically gives branches known as carotids. Now they are going to the head neck. So no point of carotids supplying anything. But it will also give the subclavians. What are these arteries? Subclavians on both the side. Right. So you only have a chance that the subclavians should be contributing to the blood supply. Agreed or not? Imagine guys, keep on imagining. There was an artery aorta which came out of the heart. It then went posteriorly. So descending aorta can't give anything directly to the breast. So it should be some branches from the arch. Arch basically gives carotids and subclavians. I mean, we can say it is a brachiocephalic trunk, fine. I'm not going into details of it. Carotids are going to supply head neck. What is left is so subclavian should be the main. Therefore, subclavian gives off the internal thoracic artery, if you remember, right? And subclavian continues as the axillary artery. This axillary artery gives off other branches like, for example, lateral thoracic artery over here. Lateral. So this is the basic blood supply. The lateral thoracic artery, which is running laterally like this, it will give off supply to the mammary gland. Internal thoracic artery running parallel to the sternum. that is internal thoracic artery, also known as internal mammary artery. This internal thoracic artery in females, it enlarges because it will supply more of the tissue. So in females it is also known as internal mammary artery, and same ways that is internal. So this lateral thoracic becomes external mammary artery. This lateral thoracic becomes, just we should be knowing the names also. So I repeat again, mammary gland blood supply are many, but mainly the lateral thoracic or the external mammary, the internal thoracic or the internal mammary. What are the other blood vessels that we can think of? See, what was beneath the breast? We had the muscles and the intercostal spaces. Intercostal spaces had intercostal arteries. Now if you go to the little bit of the anatomy, if you remember, then we know that the anterior intercostal arteries, they are anterior and there are posterior intercostal arteries. Clear? Anterior intercostal arteries are basically coming from internal thoracic. Internal thoracic we already said gave branch, so fine. What about posterior intercostals? Posterior intercostals are present posteriorly. They are coming from the aorta. Now that is the indirect branch. These posterior are basically branches from the descending thoracic aorta. But when they go around and they come forward, what I told you in the horizontal disposition of the breast, it may reach the latissimus dorsi, or it is at least at the mid-axillary level. So the posterior intercostal arteries are bigger than the anterior intercostal arteries, and when they wind around the thoracic cage, they reach anteriorly. And these posterior intercostal arteries will also supply some part of the breast, So apart from these two, which two? Lateral thoracic, internal thoracic, we have one more candidate, that is the posterior intercostal artery. Agreed or not? Posterior intercostal artery, that is the third candidate. Not a very big, but we should know. Okay, fine. Why are we trying to learn this? Because carcinoma breast, lymphatics, I told you, follow the vessels. So if there are these vessels, there should be lymph nodes connected to this, and yes, there are. So lymphatic drainage of the breast or mammary gland via the lateral thoracic, it is running laterally, and as this lateral thoracic comes from the axillary artery, the lymphatic which runs via this goes to axillary group of lymph nodes that receives maximum 75 to 80% of the lymphatic drainage, because that is a major artery supplying the mammary gland. And now 15-20% of the lymphatics will go along with the internal thoracic artery, and then they go to the lymph nodes which are known as internal thoracic group of lymph nodes, around 15 to 20%. So 75 to 80% over here, 15-20% over here. Still few percentage left, say 2, 4, 5, 6%, that goes into the posterior intercostal lymph nodes. So there is posterior intercostal lymph nodes also present. 5-6%, say approximately 5% lymphatics drain over here. Got the point? So major lymphatics are going to the axillary group of lymph nodes. That is what we trying to show you over here. This is the breast tissue. The green color is showing the lymphatic capillaries. It is a major over there going to the axillary group of lymph nodes. Right? Now if you remember our previous session, I told you in the pectoral region, what is that key structure in the axilla? We discussed our various structures. We discussed actually 3 muscles. I asked you what is the key muscle or key structure in the axilla, and the answer was pectoralis minor. Now if the axillary lymph nodes, and if you remember, if you have seen that session, I told you this muscle is dividing axillary artery and axillary lymph nodes. Therefore, this muscle divides axillary lymph nodes into 3 different levels. Now if you remember, then imagine this is the P minor of the right side. Right? P minor of the right side. Let me say right over here, and let me try to make this midline. There will be few group of lymph nodes which are present below or lateral to the P minor. There will be few group of lymph nodes which are present behind the P minor. Where? Behind the P minor. And there will be few group of lymph nodes or few lymph nodes which will be present above or medial to the P minor. Clear? Let's say breast is over here. Let me write over here, the breast tissue is over here, and these are the lymphatics. This whole is a bunch of axillary group of lymph nodes. Levels are divided according to the P minor. So tell me, this one should be level 1 or this one should be level 1. Which out of them, the upper one or the lower one, or the medial or the lateral one? Which one of group of lymph nodes should be level 1? Think and answer. Because now I am telling you that there is this axillary artery also, which then goes behind, and there is this axillary artery. This part of axillary artery is known as first part of axillary artery. This artery is known as the third part of axillary artery, and this part of axillary artery going behind P minor is known as second part of axillary artery. That is fine. But now I'm asking you, which part of lymph nodes are level 1? The lateral ones or the medial ones? Lymph nodes. Remember my words? Lymph nodes. Anyone with the answer can write in the comment box. Level 1 I'm asking. The lateral ones or the medial ones? Hint over here is the blood is flowing like this. The flow of the blood is like this. It is from subclavian artery, axillary artery, first part, second part, third part, continues down into the upper limb as a brachial artery. So what is the flow of lymphatics? Flow of lymphatics is from lateral to medial and above, and going to the supraclavicular and finally to the right lymphatic trunk or the jugular trunk on the left side. Right side, right lymphatic trunk, left side jugular trunk. So therefore, this is known as the level 1 group of lymph nodes. Level 2 is present behind the P minor. This is level 3. So any lymph node which you see behind the P minor, level 2. Any lymph node which you see below or lateral, level 1. Any lymph node which you see above or medial, level 3. Why? We have to cram it, sir? Obviously not. Because this is the flow of the lymphatic. Lymphatic capillaries are going in this direction. They have to ultimately drain over here into junction of the jugular vein, internal jugular vein and the subclavian vein. Logical, right? What was the muscle covering the P minor? There was a big, huge muscle. If you remember the pectoral region, the huge, big muscle covering the P minor was pectoralis major. So there are some lymph nodes which are present between the pectoralis major superficially and minor. So it is some lymph nodes may be present superficial to P minor. That are known as rotors. R-O-T-T-E-R. Rotors lymph nodes is given them a name. They are given a name. Rotors lymph nodes. Interpectoral lymph nodes between the pectoralis major and minor. Rotors lymph nodes. Remember rotors. Interpectoral lymph nodes. Interpectoral has 2 T's. Rotor has 2 T's. Remember. Interpectoral has 2 T's. Rotor has 2 T's. Clear? Now, considering all of this, why we need to know this? Because you should know, if you are doing axillary dissection, you are removing the lymph nodes. Which lymph nodes are involved, which lymph nodes you can save. Because if you remove all the lymph nodes, which we have to remove if the carcinoma is spread out, but they are also draining not just the breast. What else are they draining? They are draining the whole upper limb also. Remember? They are removing the whole lymphatic drainage of the upper limb also. There could be a lymphedema of the upper limb. That is one of the common complications post surgery of carcinoma breast. Okay, so remember this. If you can save, so you should know the anatomy of it. And that is what is also learned in the sentinel lymph node biopsy. Sentinel lymph node, if you have gone through surgery, are the group of lymph nodes which are first involved. So we do a special dye test in which we see the malignant cells have gone out from the tissue and what is the first lymph node that they have involved. If it is in the initial stages, you may pick up a sentinel lymph node and you may remove them, the central one and the one surrounding it, so that you can save the other lymph nodes. So we should know the anatomy of it. Agreed? I hope you agreed. Yes, good. So most of you answered it correct, right? So lymph node levels are important. Now let me show you an image over here. This is the same image. You can see the muscle P minor. Few lymph nodes are below it, few are above and few are behind, not shown over here. This is how it, because see, initially there was this classification, if you remember guys, anterior group, apical group, central group, posterior group, lateral group. Now it is very easier said than done. If you go into surgery wards and you see a carcinoma breast patient, the resident over there, or the chief resident or senior resident or the consultant, junior consultant, whoever it is, will examine you, will try to teach you how to examine the axillary group of lymph nodes. And they will tell you that, okay, behind the P major, you palpate and you have to support this hand of the patient, and with your one hand only, supporting like this, you can palpate the anterior axillary group of lymph nodes. Anterior group is behind P major, posterior group is around the latissimus dorsi. Lateral group is going more laterally towards the humerus, and central group is towards the apex of the axilla. This is how you palpate, but it is easier said than done, not very easy. And obviously when you open this out in a OT, doing an axillary dissection, it becomes very difficult to say this is the anterior group, because the segregation which is in the textbooks and the segregation which is present in the body are not the same. What you see in the textbook and what you see in the body are not the same. I hope some of you, many of you will agree with this. So the easier way device, what you can see a landmark muscle, fine. Lymph node below, 1 above, 3 behind, 2. Simple as that. So they made it very simple, and that's a very good thing. That's a very good thing. So that was a lymph node distribution, followed by, we took a base of the blood supply, and then we discussed what is a lymph node distributed, because that is important. Fine. Okay, just a second. Just a second. So that was a lymph node. Now, why we were studying lymph node? And from beginning, I am telling you that the most common pathology which is important over here is a carcinoma breast. It's a carcinoma breast. So carcinoma, I'm not going to teach you the carcinoma breast, all the classification that is a part of surgery in detail. But surgical anatomy, I would like to tell you over here that carcinoma breasts will occur in the breast, and there are 3 pictures over here. This is taken up from the surgical anatomy, surgical synopsis. Let's try to look at this image. This is the same sagittal view. Now this black is shown as a cancer or could be any other growth. Now what I told you initially, if you remember that, okay, this is the breast, okay, that is a muscle, pectoralis major. What were 3 things in the breast were? Fibrous tissue, then there was this fat, and there was this alveoli and the ducts. Clear? Ducts are opening into the nipple. Fine. Now, if this cancer involves the Cooper ligament, it will retract or it will cause dimpling of the skin. Where, sir? Over here. If this cancer involves this Cooper ligament, Cooper, if you remember, went from dermis to the retromammary space. It may pull the Cooper's ligament. There will be a dimpling present on the skin of the breast. Again, you have to ask the patient, was it from the beginning, or is it a recent dimpling of the skin? That you have to see. There's also a whole thing known as self-assessment or self-breast examination. Okay, you have to learn about it. All the females will have to see over there, even the males, because carcinoma breasts can also be present in males also. As a doctor, everyone should be knowing the self-breast examination. That is also very important. So I'm come back to it. If the Cooper's ligament are involved, they may lead to dimpling of skin. Very important. If this cancer involves the lactiferous duct along its path, and it is pulling the lactiferous duct, there will be what? The nipple will start to retract. Retraction of nipple. The cancer involves the lactiferous duct. There can be a retracted nipple, for which I had a figure over here showing you. The nipple over here, I can have a look at this. It's being retracted back. Here you have to ask the patient what I told you in the beginning embryology part. Is it of recent onset or is it congenital? Because remember, in the whole intrauterine life, it is like this only. It is just before birth that it everts out. The whole intrauterine life, it is like this only. Right? So you have to ask this question. And the third thing over here is that you all must have heard of a term known as orange peel appearance, PUD orange. So there is this PUD orange, P-E-A-U, PUD orange. Some German or French word, I guess is a French word. Fine, PUD orange peel appearance. Santare ka chilka. If you look at a orange peel, santare ka chilka, orangish color, maybe greenish nowadays, and there are small pits over it. The same thing you can see in the breast. The breast skin may look like a big orange peel, like santare ka chilka, and the dots over there, what are those? When the cancer involves the lymphatics, the cutaneous lymphatics. So third point over here, when the carcinoma is involving the cutaneous lymphatics, it is involving the cutaneous lymphatics, then there will be lymphedema only on the skin level and the sweat glands. Imagine now the skin and its interstitial tissue is not able to drain, so skin edema occurs. But the sweat glands are there, so those small pits are due to the openings of the sweat glands. That is what is known as orange peel. These are 3 things which you should know, apart from all this level of axillary lymph nodes or other lymph nodes. Why do they occur, where do they occur, and we have to keep that in mind. So retracted nipple, dimpling of the skin or PUD orange, they are signs of a growth inside the breast. It could be a cancer, it could not be a cancer. There are various things, from fibroadenomas to fibroadenosis to Paget's disease, so many things are there. Right, so we have to know about the basic anatomy and how to go through that, right? There's a small MCQ which I wanted to share with you. Just go through this and try to figure out and write the answer in the comment box if you can. I'll read out the question. The 80-year-old lady comes to the physician because of a lump in her right breast. Physical examination shows a 2 centimeter mass in the right breast with a dimpling of the overlying skin and if you so there are 2 things. There's dimpling of the skin also and there's PUD orange also. Examination of the biopsy specimen confirms the diagnosis of a carcinoma. Now the carcinomas could be a lobular or ductal carcinoma. We study all the classification of the surgery. involvement of what structures is the most likely cause of this patient's skin dimpling. So they are simply asking you a long question, but we have just seen skin dimpling is due to involvement of clavipectoral fascia, suspensory ligaments, lactiferous ducts, or the retromammary space. I hope you know the answer of this. Dimpling of skin is due to A, B, C, D. Please, I'm looking for the anyone correct answer. Yes, Sukhbir, very correct. Element aims, I didn't get it. That's metastatic. Yes, it is B. We have just seen the dimpling of the skin is due to the involvement of the suspensory ligaments or ligaments of Cooper. Hence, this is our best take over here. So, the questions like these will come. And remember over here, go through this basic anatomy. After this, remember, if you have done your MBBS or you're in the final year, go through the topic of breast carcinoma or breast in surgery. That is important. Apart from pathology, surgery, go through this. In medicine also treatment, because see the tissue, breast tissue is under hormonal influence. Therefore, it is the pathologies in the breast are more common in females because every month and after every few decades there is sort of hormonal turbulence which is happening inside the female's body. Therefore, the breast is commonly involved. So we should know the basic anatomy, and that should form your base. If the base is good, if you understood the anatomy, then you can add the pathologies. And whatever pathologies you can add, you should know breast, where does it lie, what is inside the breast, what is the blood that is supplying the breast, and what is the lymphatics that are draining the breast. Simple as that. So that is all about the topic. I hope you enjoyed the session, guys. And that's all from my side. Thank you for your time, and hope to see you day after tomorrow. We will have another session. And at same time, 7:30 p.m. Hope to see you on a Friday evening. Thank you.